Yeah, fine. It's gonna be enough. Okay, good morning, everyone. Welcome to Wigan. Happy New Year. For those I've not seen before. Obviously, the NHS has been in the news quite a lot recently, partly because, of course, we're coming up to the 70th birthday of this fantastic organisation, but also, obviously, it's been in the news with the winter pressures, which I'm not sure are really accurate. I think if there are any problems in the NHS, they're systemic and we need to sort them out, not just in winter, but the whole year round. Anyway, we're all trying to do that, I know. So can I just ask people if you would, if you want to speak, make sure you say who you are and which organisation you come from, because obviously we've got the television streaming going on today. Lindsay, can you record the apologies? Yep. The minutes of the meeting held on the 13th of October are circulated. Are those okay? If not, straight to John for his Chief Officer's report.
Thank you. Apologies for that. Good morning, everybody. And I've got quite a lot to say under the report this morning, because obviously the report encompasses performance, finance, quality, a number of other issues. So I won't go through it word for word, but I am going to pull out a number of items. I also am going to just add a couple of more up-to-date issues that I wish to reflect. Starting from the front end of the report and the news items, I do want to draw attention to the fact that we now have full approval from NHS England to take on responsibility for a large part of the specialised mental health commissioning functions. This has been hard won, and a lot of people have contributed to making that happen. I want to particularly pay tribute to Sarah Price for her leadership, to Sandy Baring as well, who did a lot of the deep work on the case for change, to Tom Tasker as well. And I can't say thank you to everybody today, but it's really been a team effort. So having taken responsibility for those functions from the 1st of April, or will be doing from the 1st of April, got a time of preparation now. We're not going to try and change everything at once. We don't have the capacity or capability to do that. So we're going to focus first on CAMS, Children's Tier 4, which is the highest level of provision for children. Why? Because under our Thrive model, which we're trying to create within Greater Manchester, it requires us to break down the barriers between different levels of intervention for children and young people, so that they can move much more flexibly between the types of provision. Also, we know that we've got an unwanted track record in Greater Manchester of children and young people having to be moved out into beds well outside of Greater Manchester, and we need to take action as swiftly as we possibly can to eliminate that practice as far as possible, and to ensure that as many of the children and young people in Greater Manchester can be cared for here or very close to here. The second thing I just want to mention, which isn't in my report, is there has been some significant coverage over the last 7 to 10 days of the whistleblower case and the letter from clinicians at the Royal Children's Hospital here in Manchester, expressing concerns about staffing levels with respect to critical care for those children and young people. The first thing to say is that Manchester Foundation Trust themselves have issued a very clear statement on this matter in terms of the seriousness with which they have taken those concerns and the actions they have taken since to understand that situation and take the necessary actions. Beyond that, the Francis report, which was done after Mid-Staffordshire, sets out very clear procedures for how different parties should act and their responsibilities when such concerns are raised. And we will obviously be liaising with the CCG, the lead CCG, Manchester Commissioning Organisation, about the assurances that they are gaining around quality and safety going forward. We are liaising with NHS Improvement as the regulator in terms of their responsibilities as well. And then later in the year, we will be expecting that in any event, nothing to do with this, that there will be a full CQC inspection of Manchester Foundation Trust, as we would expect for any new trust, given, of course, MFT is a merger of the two previous organisations. And I'm sure on top of all of that, the board of MFT are assuring themselves around the safety and quality of provision. So very important to understand that all parties are taking this seriously and are seeking to ensure that the provision of care in that unit is safe and to the highest quality possible. Finally, in terms of the opening of my report, just want to let people know that we are expecting the planning guidance nationally for 18-19 for the NHS to be published either today or Monday. And what that will set out is how the extra money in terms of the budget before Christmas will now be allocated to the National Health Service. We can also expect, I think, some new requirements alongside that money, which will obviously need to be reflected within our devolution accountability agreement, and that will mean making some adjustments to some of our targets and some of the ways that we assure the system over the coming year. In terms of performance, again, I'm going to take the report as largely read and very happy to take questions, as are my senior colleagues. But the one thing I do want to just talk about a little bit is with respect to winter, one of the issues that we've needed to deal with was the national guidance that came out just after Christmas around the potential cancellation of elective care, elective procedures and potentially outpatient appointments as well. We have sought to take a proportionate approach to this guidance within Greater Manchester and to only cancel procedures where we believe it was absolutely necessary to do so for the safe running of our non-elective care, our urgent and emergency care. Having now aggregated the position across all of our trusts, the current position is that we are expecting just under 14% of procedures to be cancelled in January, which we think is as few as we can manage in terms of trying to maintain as much of our work as possible, recognising the huge amount of inconvenience and potentially stress that delayed procedures can cause. Clearly, we will also and are planning for recovery in terms of ensuring that those procedures are rebooked as quickly as possible over the coming months. Of course, this position could change if we were to get, for example, a significant increase in the flu outbreak in terms of pressures on A&E, and if that was to happen, obviously I would keep the partnership and the broader public informed. But for now, I'm very grateful to our trusts and our CCGs and our local authorities for their partnership in this matter and minimising the number of procedures that have needed to be cancelled. I'm pleased to say that we've also managed to maintain most outpatient appointments as well. A couple of other things on quality now. I think we have had a growing concern in Greater Manchester by the succession of Ofsted CQC reports into special educational needs provision. And we've had a number of our localities, and they're named in the report, who have received poor reports and have been asked to take immediate actions to rectify the quality of provision. Clearly, for a sub-region that is absolutely committed to children and young people's health and well-being, it isn't acceptable for that cohort to receive a substandard service. So this is an issue that the Children's Health and Wellbeing Board have looked at in some detail, and we will be making recommendations, particularly to the Directors of Children's Services, but also to some extent to ourselves as the NHS, in terms of the improvements that need to be made. Finally, on care home quality, we've set out a graph there that shows you where we are right now, but I just want to take the opportunity to commend Salford, because Salford have made quite remarkable levels of improvement in terms of the percentage of their care homes that are good and outstanding compared to where they were a year ago. And I know that's been a huge team effort to get in that intensive support to those care homes and enable them to make that level of progress. They realise there's still more distance to go, but given that a year ago we were looking at a number of boroughs, Tameside, Salford, Stockport and Manchester, who had far too many homes that were requires improvement or poor quality, to see Salford really get to grips with that and make a significant level of change is very encouraging, not just to them, but to the others that still need to make similar levels of progress. On finance, I'm just going to get Steve Wilson just say a few words on the month 6 position. If that's okay, Steve.
That's fine. So obviously this is month 6, so it's slightly out of date now. We'll be taking the latest report through SPBE next week, although there isn't a huge amount of change at the moment, but it does remain a really challenging financial position for 2017-18, particularly on the provider sector. So the month 6 report shows that we are at month 6 expecting to fall short of the planned financial position, and that's because of some issues on the provider side, which is Pennine Care not expecting to deliver their agreed plan for the financial year, and a number of other trusts falling short of the required A&E performance to attract the maximum sustainability and transformation funding from NHS Improvement. So it is forecast at this stage that we won't deliver those plans, but I do think that the coming months are going to be really critical in making sure that that level, at least that level, is maintained. And I know particularly as we move into quarter 4 now, there will be some real significant pressures on the provider side. So we'll continue to update the board and continue to work hard on doing all we can to mitigate those financial pressures in the last quarter of the year.
Thanks, Steve. And then finally on transformation, again, I will take the report as read, but on primary care reform and the development of our local care organisations, a delegation of accountable care systems plus us, when we're something different as a devolved system. But together, we went to 10 Downing Street yesterday to meet with the Prime Minister's advisor and to talk about how they could support the rollout of primary care at scale and the work of our neighbourhood clusters. And so I'm going to ask Dr. Tracy Vell, who was our representative at that meeting, just to give some feedback.
Thank you, John. So we went down as a delegation, really talking beyond in Greater Manchester, beyond just general practice, of course, but more about our communities and our collective LCOs as part of the accountable care system. In the room were representatives, obviously from the government, but from the Treasury and the Department of Health. And first, it was a talk through of the progression that we've made in doing the development reviews of our LCOs. It's absolutely fascinating, and I take this opportunity just to thank localities for the amazing work that they are doing, and it's starting to have impact already. So I was able to share that and how much progression we've made. Also, of course, when you've got the opportunities to bring up some of the difficulties we're having. So they're not just in general practice, they're around estate, contracts and investment that would enable that process to be much smoother than we are finding it at the moment. But also, of course, for general practice, there's some deep issues around their contracts and their estate, as we know about. But we left the meeting with, I had an ask that the narrative that the government gave will be improved in terms of support for our general practice who are innovators and able to flex much quicker as small flotillas rather than big tankers. We can flex and move and change direction much quicker. And we'd like the narrative to be very positive towards both general practice, primary care and our community work.
Okay, thanks for the report, John. Contribution from Steve and Tracy. Any questions or comments on that? Brenda?
Is that the right one? Thank you, Chair. Brenda Warrington from Tameside. Brenda Warrington from Tameside, thank you. I have 2 questions, Chair, if I may. One of them really is a question to John, asking whether he managed to make any progress with government relative to the capital funding that we need, certainly in Tameside, to ensure that we can get the primary care streaming up and running, which was held up because of the control total issues. John, you said that you would be supporting us and getting involved with government. I just wondered if you had an update for us. And if I can just move straight on to my second question, if I may. It's about the transformation fund. And actually, it was purely something that I heard on the radio driving in this morning, and it was very brief, but it was an indication that there are, and this is not necessarily Greater Manchester, I hasten to add, but there are areas of the UK where transformation funding is actually being used to shore up services as opposed to introducing the transformation that it's intending to do. I'm seeking really assurance that that is not happening in Greater Manchester and asking what kind of checks and balances we have in place to make sure that that doesn't happen in Greater Manchester. Thank you.
So, they're really good questions, both of them. So on the first, we have continued to make representations, and the best position we seem to reach with government is that basically said that they would only really contemplate the possibility of release to Tameside and Stockport if we as Greater Manchester could make a commitment in year that we would effectively definitely meet our overall control total, so aggregating the pluses and minuses across the system, which they said was, well, that's a true expression of devolution. That wasn't a bad offer, actually, but the problem was that at that time, and even now, actually, we couldn't give that guarantee. I mean, you've already heard from the finance report from Steve that we're in a deficit position right now against plan. So if we were, even in the next month or so, to reach a position where we were absolutely confident that we were going to come in against plan in total, then there may be a possibility to unlock those resources. So that's where we got to with them. In terms of the transformation fund, this is a real and present risk. And we built this into the investment agreements to make clear that transformation funding could only be spent on transformation. And we've put in a clause within those investment agreements that makes absolutely clear that transformation funding can be curtailed, stopped, paused if we find that it is being used for purposes for which it wasn't intended. And we are putting in place a monitoring system in terms of tracking how the TF is being used and obviously tracking the metrics as well. We will take this very seriously because in terms of reputational risk, it is very significant, and this will be part of our assurance and dialogue with clinical commissioning groups.
Any further questions? John? Nope. Okay. Thank you, John. Move on then to the Transformation Fund report. Steve.
Thank you, Chair. So apologies, it's quite a long paper today because we have had a busy period in terms of the work TFOG did to assess bids for the Transformation Fund and those recommendations going forward to SPBE in December. So the board today is asked to note the decisions that were taken by SPBE in December, which was around 4 substantive investments. I won't go through these in detail, but I'll just draw out the highlights. So 2 of those 4 were effectively the final bids that we'll see coming through, the final allocations that we'll see coming through for the localities across Greater Manchester, and they're both phase 2 bids, so they both build on initial allocations. The first one to Salford, which was for 3.44 million, which was to add critical work around the population health work in Salford that wasn't part of their original Vanguard programme or their original bid for the Transformation Fund, so that completes the work across the full range of services in Salford. And alongside that, we had phase 2 bid from Wigan, appropriate as we sit in Wigan today, which was for £15 million, and that builds on a phase 1 bid. So Wigan had set out that they would always bring these 2 bids in phases, but we were particularly clear at the Transformation Oversight Group that we tested the alignment between the 2 phases and understood how the second phase built on the first phase. So those were the last 2 through in relation to localities, and they'll take our locality investment to around about 275 million out of the 450 million, which is pretty much exactly where we forecast the allocation to be in terms of locality investment. So that concludes that process. The other 2 bids are around in relation to mental health, and members will recall that when we looked at the mental health strategy in July 2017, we set an overall funding envelope for mental health, but we said that any individual bids that were greater than 5 million against that total of 56 million investment in mental health strategy would come back for individual assessment. So we've received the first 2 that fit into that criteria, and that's a 13.44 million bid for children and young people's crisis pathway services and 14.24 million for liaison mental health services in acute hospitals. So all four were recommended to be approved and subsequently approved at SPBE in December. Important to remember, as always, any allocations come with a number of material conditions, and they are significant, and they will need further work to be done before we can sign off final investment agreements in all of those areas. But they have been approved, so the paper is here for the board to note today. Happy to take any questions.
Okay, thank you, Steve. Any questions on that? Nope. We agree. Nope, those recommendations. Thank you. Move on to the governance review proposals, John.
Thank you. The development of the governance proposals has been happening over the period of the last 6 months, and this is the culmination of that work and bringing here to SPB, hopefully for final endorsement agreement, so we can get on with implementation. The work of the partnership under devolution has gone so far, I think, through 3 distinct phases, or rather we're entering into the 3rd phase now. The first phase was from the point that the agreement was made at the end of 2014 through to us taking charge in April 16, and we had a very specific governance set up during that preparatory phase. Then, as we took charge in April and through those first few months, we put in place the governance as we know it now, with a strategic partnership board and a strategic partnership board executive, with the executive doing work, making agreements, and then coming to SPB, and essentially the same work being looked at again through to endorsement. When we looked at the governance as part of the review, we found a number of deficits with it. One, there was significant duplication. Second, we felt that we'd lost something that we had at the beginning of the process in terms of a real consciousness around what matters to the public and the expressions that they made at the time we did the large engagement in the spring and summer of 2016 around what they thought was the most important items. And we also thought we'd lost to some extent the service user and carer voice within the work of our governance. At the same time, we felt that we proliferated in terms of the amount of sub-governance and that people were spending too much time coming to meetings rather than actually focused on the frontline transformation that we wanted people to be most engaged in. And there was a need, frankly, for some level of cull of the amount of governance that had emerged over a period of time. And then third, there was a view, which I think everybody crystallized on, that we'd lost something of the dispersed leadership model that we'd all aspired to and built into our framework at the outset. That a lot of stuff had been centralized and too much of it was being, frankly, led by me and my team rather than being led by different parts of the system. And we needed to make far more of the work of the Provider Federation Board, the Voluntary Sector Assembly and Alliance, the Commissioning Group, AGG, the local government groups, the DASs, DCS, etc. We need to push far more out than we had done at that time. So the governance review looked at how we might do that, and it's come up with a set of proposals. One is that this group is going to be meeting today, if you agree the proposals, in this form, really for the final time, because what we want it to become is a much more public-facing health and care board for Greater Manchester, a little bit of a non-statutory health and wellbeing board, although we wouldn't use that term to distinguish itself from the local statutory health and wellbeing boards, but focusing far more on the social determinants of health, the public service reform work of the Mayor and the combined authority, and which is going on obviously deep in localities as well, bringing the Mayor's plans around homelessness, school readiness, ageing into this forum, and considering what our health response and responsibilities are, health and care response and responsibilities are, and ensuring that they are enacted to really get back on the front foot around our public engagement and bring that voice through Health Watch and other mechanisms far more into this space and get the public to determine more of our agendas and what those priorities actually are. So it'll look and feel different. I'll give you an example. In May, we're going to be bringing the Children's Health and Wellbeing Strategy. When we bring that strategy, I expect we're going to have children and young people, and as well as their representatives here or in the room that we're in, actually in hearing their voice because they've built up that strategy, they've stated their priorities, and we are reflecting them. Below that, the executive will do more of the grind in terms of the work, not just in terms of the day-to-day oversight of the system and the progress of our transformation programs, but also around developing our target operating model for the future at the end of that transformation phase. And we will get more formal, actually, about the work of that board. You know, we have sectors there with voting rights who have got really important representative responsibilities, and we need to ensure that they feel those responsibilities and they're organised when they come into that room to represent the interests of that group and the constituents that they serve. We'll then reduce the amount of governance below that. We're only going to have 3 main boards in the future. Performance and delivery, absolutely important in terms of our stewardship of the system, quality and safety under our medical director, but also covering social care as well. And then third, finance under Steve's leadership, but with the local authority treasurers and the finance directors from the CCGs and the trust working together on our system finance as a whole. We will continue, of course, to coordinate the portfolio of transformation programs and projects and make sure that they are being stewarded correctly. And in terms of dispersed leadership, we're going to give far more responsibility for delivery of programs and projects to different parts of the system. That's one of the reasons why we've set up a commissioning hub under the joint leadership of local government, the combined authority, the CCGs and ourselves, under Rob Bellingham's leadership, and I'm pleased he's here this morning. And increasingly, we will be pushing a lot of our asks from our programs to the commissioning hub to get the commissioners collectively to take responsibility for ensuring that that is delivered, those programs are delivered systematically and consistently across Greater Manchester. There's a lot more in the report, but you can read that for yourselves, and I hope you will endorse this direction of travel and our shift to this new governance model for the third phase of our work.
Thanks, John. Andy, do you want to say?
Thank you, Peter. Just to strongly endorse what John said and the direction that's been set out, and to thank this board for the work that it's done so far. It's really helped take us to this point where we are considerably further down the path towards a reformed integrated service in Greater Manchester. But I think the change to a Greater Manchester Health and Care Board, I think, is now the right change to make at this particular moment in Greater Manchester's journey. Through the Reform Board that meets at the GMCA, you know, we have begun to really take that broader view of the life journey and the way we need to break down silos between public services at each of those crucial moments in life to improve how we work and actually to get a focus on prevention in a way that we've never been able to do before when we're working in our separate ways. So colleagues will know that we've had that huge focus on school readiness. All of the evidence tells us that if you improve those early years of life and ensure that children are developing at the right rate and are ready for school, you will do more to improve their health throughout the course of their life than probably any other intervention that you can make. And I'd like to thank John, Warren and all of the team for the way in which they are engaging with that public service reform journey that we're beginning to set out at the Greater Manchester level, but also on homelessness, which John mentioned, which is, of course, a priority of mine and of the other leaders in the CA. We, through the Reform Board, believe we should have a more urgent conversation about what more we can do to deal with the unacceptable crisis, that's what it is, that's been unfolding before our eyes and is affecting all boroughs. And I just want to put on record my thanks. It's in the Chief Officer's report, actually, the proposals that were brought to that board by the Health Service, the commitment around helping people with no fixed abode to register with a GP. 500 people last year, were able to do that. Also, the commitment not to discharge people from hospital to no fixed abode or back onto the street, again, has made a real difference to people. And I know that efforts are ongoing to look at mental health outreach across Greater Manchester and to see how we can improve that. So I think it just was right for me to say, I think this is the right moment to really put at the heart of our arrangements that broad focus, person-centred, place-based, looking at prevention being at the heart of everything that we do. So just wanted to put on record my endorsement really of the journey that's being suggested here. I think it will reinforce everything that we're trying to do.
Thank you, Chair. I also, Brenda Warrington from Tameside, also would like to endorse the report. Just a couple of things I would like to highlight, though, when I was sort of reading through it. I think when we're at the point of engaging with the public, particularly, I think we have to remember that members of the public can be very easily put off when there's a lot of sort of council speak, let's say, in huge reports, you know, that are not that easily read, quite frankly. And I think we just have to be aware of that and engage the public rather than, without intending to, we can sometimes put them off by the very kind of reports that can be presented. We do have to be person-centred. We do have to make sure that our public across the whole of Greater Manchester is with us, working with us, and knows, you know, what our ambitions and visions are. So we do have to engage them through all of the different forums. And I would just ask that that be taken into account whenever we're in a situation of engaging the public. My one question on this is simply, is there an additional cost to this change of governance to the Greater Manchester Health and Social Care costings that exist now? Thank you.
There is absolutely no additional cost to the governance. In fact, if anything, it will reduce because there's less boards and therefore less meetings to service with Secretariat and room costs and all that sort of stuff. So, if anything, it's a net saving.
Thanks. Bev Craig, Manchester. It follows quite nicely on from Brenda, actually, in terms of I think it is the right time that we're starting to be seen, I think, as more open and more welcoming to people's perspectives from Greater Manchester. I think as a system, we're not perhaps seen as the most accessible of structures. And I welcome that obviously we live stream our meetings, but engagement has to be much, much more than that when we're talking about proper citizen-led shaping of agendas. And that won't be without its challenges. I think the colleague perfectly made the point around accessibility and the challenges for ourselves that we'll have to address when we want to obviously not patronise the public, but get that balance between ensuring that they have a say in strategy versus strategy and actions that are easily accessible. I also wanted to commend the reference to the engagement of the voluntary and community sector reference group. I think this is a good mechanism for how we try to engage and involve the sector in the future that allows them ownership and discussion amongst themselves around prioritising their own key agendas. And the final point really was more of a plea that as we move to a system that tries to engage and involve people much more widely, we see people as people, not just as patients. And if in our presentation of stories and voices, we do that in the context of a person that might access a myriad of services, not necessarily just one example of a potentially health-led process where something is done to that person. So I think there's a real opportunity to us to be quite innovative in how we ensure that that voice is involved.
Alex?
Thanks, Chair. I'm Adam Irvin. I'm from Primary Care Advisory Group, and I think absolutely support the plans. It's the right thing to do, particularly like the distinction between the public-facing elements that colleagues over there have just mentioned, and I think it puts an onus on the partnership executive to get plans into a format that is engaging and actually tells a story of what we're trying to do. I do have one small discrepancy between the pros of what the report says and some of the terms of reference. I think in the Health and Care Board, there's an oversight where we've carried over primary care membership just through the LMC rather than through the wider primary care advisory group. And I think the agility and the responsiveness of all of the primary care providers is crucial, as Tracy mentioned earlier. So I think that's just a small correction on page 27 that we should make.
Thank you for that, and I apologise for the error. Of course, it is meant to represent the whole of the Primary Care Advisory Group, and you're right, that's just a carryover, and we'll get that amended straight away.
Thanks, Peter. Just picking up on Bev's brilliant point there about people-centred approaches, and I think the paper that Giles Wilmore, who works for John, is going to be bringing forward, hopefully to the executive shortly, will pick up on that, about how we can really embed that within our integrated care organisations, within GP practices, within place-based working. And when Will Blandimer does our presentation later on, you'll start to see how we're starting to think in that way as well. But it's really a good point, well made.
Okay, thank you for the comments people have made. I think it's a sign of the growing maturity of the arrangements that we have in Greater Manchester that we can move on in this direction. I can remember, John, we were here when we began these partnership meetings of the 37 different organisations in GM that had an interest in health and care. We got together, we all turned up, people didn't come on their own, so there was pretty big meetings, and there was a bit of suspicion amongst people, but I think we've got over that, and I think people are genuinely working together now to improve health and well-being across GM. So thanks. So, can you agree with the report then? Thank you. Business plan, Warren.
Thank you, Chair. And I think in the light of the last conversation, I'll start by recognising I've got my personal development review with John at the end of this month, and I'll definitely add the density of the reports that I've produced for this board over the last couple of years as one of my development needs. So, having said that, I'll have a go at trying to pick out some of the highlights, if I may. This is a kind of a half-year update on the business plan that confirmed the partnership's priorities for 17-18, and I can't do justice or cover all of the elements of the work that's contained in the summary paper, but I do think it's worth the board reflecting on some of the headlines and highlights. And I think in terms of some of the work directly aimed at improving the health of Greater Manchester residents, and in particular that initial focus on starting well and early years, I think there are a couple of kind of really significant points of progress in relation to the work to improve the oral health of children from birth to 5 that's now starting to be mobilised. The coordination of the support for school readiness and tackling early developmental delay across Greater Manchester, and in applying a consistent approach to reducing the numbers of women and their partners who smoke during pregnancy. Additionally, I think it's worth recognising that the first steps in the implementation of our cancer plan, including examples such as the pilot lung health check, will genuinely start to shift the dial on our approach to early diagnosis and increasing survival rates. And I think one of the most significant things we did over the summer was the approval of that really significant £134 million investment framework for mental health. And as the board has already heard through other items this morning, we're now starting to pull through the business cases and develop the services that apply that investment, and starting to see the new services develop in hospital-based mental health support, in perinatal care, in the extension of children and young people's crisis provision. One of the most significant changes, in fact, we could say the most significant change that we will make through this journey with the Health and Social Care Partnership, of course, is the change in the models of care that we apply and the mobilisation and development of the local care organisations. As Tracy's indicated earlier on, we're about 3/4 of the way through the engagement with the practitioners, leaders, activists driving the mobilisation of those local care organisations across Greater Manchester. And we are going to bring a more substantive report on that rate of progress and some of the highlights from there. But I think we're genuinely starting to see amazing stories being told, and in particular, as we start to mobilise those neighbourhoods and seeing real activity in those neighbourhoods, seeing genuine leadership, seeing genuine co-production, seeing the multidisciplinary teams take shape, seeing the care coordinators, care navigators, both coordinating direct care, but also supporting much more scaled approaches to social prescribing, coming to life in all parts of Greater Manchester. It's not a universally consistent story, but it feels compellingly positive in terms of those developments. And we're already starting to facilitate a kind of rapid sharing of that progress across the LCOs through the peer elements of those conversations. Similarly, I think it's worth recording that the support and the activity of the community learning disabilities teams, I think, nationally recognised as making enormous progress in Greater Manchester in supporting people to go back to their communities and be supported to live in their communities and come out of what in some instances were very long institutional hospital stays. The Mayor's already mentioned the coordination of the support for homeless, whether it's people who are rough sleeping or whether it's families in temporary accommodation. And those examples of support now, whether it's registration, supported discharge, or the provision of health services in homelessness settings, is now being increasingly spread and shared. I think one of our kind of key challenging areas where it's still worth recording that we've made some significant steps to introduce some stability and consistency is around urgent and emergency care. And recognise the work that we've done to provide urgent primary care service on a 24/7 basis, redirecting patients away from A&E, in terms of the integrated discharge support that exists in every part of Greater Manchester around each of our hospitals, and the establishment this winter of the coordinating operational hub to give us much better early warning and intelligence where pressures are building in the system and where we can support each other in alleviating some of those pressures. I think on the ambitions that we set out for addressing variation, increasing standardisation in our hospital provision, it's worth our recording significant progress in the establishment of on the back of the most significant hospital merger in the country, the first stage establishment of the Manchester University Foundation Trust and the progress of the Northern Care Alliance between Salford and Pennines hospitals. And I think that kind of connectedness across Greater Manchester is part of the reason why, in the same period, we were successful in attracting £93 million worth of capital investment into Greater Manchester for Healthy Together and major trauma services. Last couple of points, I think, on innovation and some of the enablers, in that where the work on genomics and cancer and the advancements that we're going to be able to make in terms of precision medicine will be increasingly significant as we tailor health to an individual's unique genetic makeup. Also recognising that, and Councillor Warrington, I think, kind of touched on this earlier on, we're at the start of the journey around the investment in the critical digital infrastructure. £10 million allocated in this last period, and we're still seeking the full complement of Greater Manchester's share of that national digital transformation. And then the final point really around the workforce transformation strategy and the progress that we've started to make there, with attracting overseas doctors through the extension of the Learn, Earn and Return programme that started in this part of Greater Manchester and is now spreading, and the better coordination to respond to our kind of key workforce gaps, and in particular attracting and supporting nurses in education. So a half-year report, and obviously the board will expect that we'll be doing the work now on this year's annual report as the conclusion of the year's work as a bookend, with the bookend of the next year, the 18-19 business plan to confirm and set our priorities for the coming year as well.
Any questions, comments? Chris?
So, Chair, Chris Brooks, Chief Doctor, Salford Pennine Northern Care Alliance. It's been really challenging times in urgent and emergency care, and I'd just like to recognise the fact that colleagues have been working across the system, which I think is different now to how things were previously. And care in the past, agencies working in a fragmented way. I think my point is that in the current issues that we're dealing with, and very challenging, I'm much more confident that agencies are working together in a more seamless manner, such that we can move patients through the system. And although we've got very challenging times, and although services are under immense pressure, I think we've escaped some of the real very serious issues that other areas are facing. So I'd like to recognise the contribution of all of our staff, but also to recognise the fact that colleagues have been working together across boundaries in a way which is supporting care across systems. I think that's been a big difference this year compared to previous approaches that we've had in that manner, which has helped support our patients in these difficult times.
Chair, it's very pleasing to see that the rate of smoking is reducing within Greater Manchester, but I saw a report not too long ago that young people were, in fact more young people were taking to recreational drugs than they were smoking. I just hope that we're not storing up a future mental health problem instead of a future pulmonary problem, and see if we can also take that into account when we're doing the smoking issue.
Thank you, Chair. Brenda Warrington, Tameside. Just a point that Warren mentioned, actually, and I do want to ensure that a lot of credit is given to Tameside and Glossop Integrated Care Foundation Trust for the work that they are doing on the digital health, which now is working directly with our CRS, working directly with the ambulance service with NWAS. And what's happening is it's proving very beneficial to care for our people who now are not having to undertake those what become unnecessary trips in ambulances to hospital and the time and cost of that. But also it's proving very beneficial to people in their own homes that need that care as well. So again, we can be sure that people are looked after properly, have the right kind of care, but are not unnecessarily being taken out of their homes and transported unnecessarily to a hospital site. And it really is proving very, very cost effective, I would like to say. And if this board is interested, I'm sure we can get some figures to just demonstrate how cost effective it has been in a very short period of time. Thank you.
I think, Brenda, we could perhaps have a presentation to the board at some stage. Anyone else want to comment on these before we bring Warren back in?
Just to kind of follow, because I do think it's worth sharing that kind of specific example. We did a sharing exercise across the LCOs a few months ago, just before Christmas, and I can't tell you the level of interest and excitement that Digital Pete is the person behind it attracted, and I think you're right. It's definitely worth seeing the numbers behind it, because the impact is hugely disproportional to the to the investment and the people involved.
I just wanted to quickly give Brenda some feedback that number 10 know about Digital Pete also. But just to say that our community response service that we are about to launch is also using the technology that you started and rolling it out so that all localities can replicate what you've discovered in Tameside. So thank you.
I'm not sure endorsement from the Prime Minister is what you're looking for, is it, Brenda?
If I can just say, Chair, DigiPete is ours. We're keeping him. Thank you.
So this is Steve Barnard's report, who's our head of service improvement jointly with NHSI for A&E, but he's hard at work on overseeing the system, and so I've said that I would deliver this report for him. The first thing I want to do is just echo the comments that Chris made a few minutes ago, Chris Brooks, in just recognising the extraordinary efforts of staff across NHS and social care over the last couple of months. I've visited most of the A&Es in Greater Manchester over that period, particularly since New Year, You know, some of them, I have to say, look very tired, but you know, just checking in with them and talking to them, what has been unwavering has been their dedication, their commitment, their determination, their teamwork, their morale. I mean, it is extraordinary, actually, and you know, clearly we have to create, both at local and national level, a more sustainable framework for them going forward. But you know, they have risen magnificently to the situation. As Chris has also said, the last few weeks have been an exercise in teamwork across Greater Manchester, and although you know, our performance has not been stellar by any means in terms of 4-hour waits, actually I'm very proud of the fact that to this date we have had none of our systems in Greater Manchester go into a critical incident situation. In other words, we've maintained OPAL 3 or below. And there are some particular reasons for that. Obviously, the quality of the operational management within the trusts and the localities themselves, but actually the introduction of the Greater Manchester hub operating from its co-located position with NWAS, looking at data feeds, some of them live, some of them at least updated every 4 hours from those hospitals who are able to do it digitally, has just given us a huge advantage in being able to see where problems are arising or to predict them and to take early action, whether that's an ambulance diver or getting some NWAS senior crew actually out to the hospital to help with the cohorting and the triaging, or actually having conversations with the CCG and local authority early about an intensive approach to discharge at a particular time. It has been a really, in my view, valuable innovation that will go from strength to strength, I'm sure, as we build up its data and its analytics over time. I must also say a huge thank you to the whole system for performance on delayed transfers of care. Other than one small spike for a few days in early January, we've managed to keep our delayed transfers under 4% on a whole across Greater Manchester. There is some variation in that, but every system has worked really hard to seek to minimise discharges, and we've done far better than we did 12 months ago, and thank goodness we have, in terms of the level of demand that we've been facing. So the situation is stable at the present time, and we are deploying, although it came very late, the extra money that the government has made available to us, and we're seeing some benefits from the deployment of some extra resource. But looking ahead, while we will continue to improve our systems locally, the reality is if we want to avoid this in future, then at the end of the day it does come down to resources. We have to replenish our workforce within the NHS and social care, and that won't be easily done. And we have to build up capacity in terms of both the physical constraints within our A&Es and the difficulties that creates in terms of operational environments, in operating in units that were built years ago for a far lower number of people, but also our capacity in the community as well, in terms of the availability of intermediate and nursing home beds and domiciliary care packages. We can't solve all of that locally. We will, through innovation, solve some of it, but we need a different national settlement. Thank you.
John, Andy?
Thank you, Peter. I visited the hub just before Christmas, and then went back and spent some time shadowing a 999 call handler on the Princes Parkway just after the break, the 3rd. And what I saw was, quite striking, really, in terms of the pressure that was on the system. I think all the staff were saying it was unprecedented. Tuesday, the 2nd of January, I think it was, they said was a day that they'd never seen volumes of calls or pressure like it, and yet it coped. And I just want to echo what Chris said and also what John said. I mean, the lengths people have gone to make it work are extraordinary, and we do all owe you, and through you, the staff in your organisations, a huge debt of thanks for managing that pressure without going into a critical situation. There's 3 points, Peter, I want to make briefly, which actually pick up on what Chris said. The sense came over to me, and this was true after the arena attack, it's also important to say, of Greater Manchester increasingly operating as one system. That came over and is coming over quite strongly. Real partnership, management across the whole of the Greater Manchester NHS, and I think that is something to be proud of, but also to keep building. And I think because of that approach, I think we are improving our ways of working. So I think that one system approach, I think, is absolutely the way to go. And Chris was right to point to it. The second point I would want to focus on was actually something that John said earlier in today's meeting, and that was around the I think he said proportionate interpretation of the guidance that came out early in the new year from the government around elective work, and it came over in the media anyway that was almost a blanket postponement of planned operations, which is a problematic statement, I would say, in terms of the range of work that's going on in the NHS. And I was pleased to hear John say that there'd been a kind of a Greater Manchester interpretation of that and a balanced approach, to the point where I think I heard a figure given that only 14% of operations had been cancelled. The reason I just wanted to focus on that is because, for me, that brings home the benefits of a devolved health and care system, that we were able to take a different view, and in taking a different view, not subject patients here to unnecessary distress by having operations cancelled when they needn't have been cancelled. And I think that is a really important point. Having asked for more devolved control of the National Health Service, I think the onus is on us to say, well, what are we doing with that devolved control? What decisions are we taking here that are different and also benefiting the residents of Greater Manchester? And I just want to praise John and those involved in taking that considered approach, because I think that has been clearly the right approach to take. And I think going forward, again, thinking how we demonstrate the difference that we're making and the different decisions we're taking through devolution, and therefore better decisions, I think is something we should continue to be proud of and to promote. The third point, Peter, is just to kind of touch on what John was saying. I mean, what we've seen over recent years is the pressure ratcheting up every year. Every year seems to me to have been slightly worse than the one before, and it just grows all the while, and the funding situation obviously lies behind that. The debate in recent times about A&E has often been about people inappropriately turning up at A&E. Now, that is, of course, always part of the issue, but I think we've got to move the debate away, actually, now to the reality. And the reality, as far as I can see, is we've got both record numbers of people turning up at A&E, but record numbers of admissions through A&D. And that tells us that it's care in the home that is nowhere near as good as it should be, and that the system at some point won't be able to manage. So what it does do is point to a new model of care that we have been discussing here in Greater Manchester, a new model perhaps for the ambulance service, better able to support people and treat people at home, working with GPs, picking up on the points Tracy made around the GP workforce. That's something we should certainly think about, but much more broadly, going back to that idea that was put forward to the government at the budget around Care 2020, and in setting out in clear language, Brenda, what a new model of care might look like for Greater Manchester, that really does start in the home, that is person-centred, as Donna said, starts there, is preventative, and can manage that journey home to hospital and back again, that optimises the patient journey. It cannot be right that we leave older people to arrive in a very delicate condition in A&E and then to spend a long period in hospital. So I think the time really, it couldn't be clearer, could it, that there is a need now for in this 70th anniversary year, there is a need for a new model of care in the NHS, and I think we now need to get on with saying to the government very clearly we want to get on with building that. And I do feel it is about saying, you know, the old approach of payment by activity, it isn't actually going to deliver the right answer in the end. It will sustain the idea of a treatment system that just treats when people present. We do need to move to a different model of payment that is about incentives to support people in their own home. And I want, and I'm sure you do, want Greater Manchester to be at the forefront of that. We're going to come on to talk about carers, and I think that's very much a part of it as well. So I just want to thank everybody for what has been done to, well, get us to this point, which is still a difficult winter, but obviously now we do need to turn our minds to the reforms that are needed to improve things going forward.
Okay, thanks, Andy. Any further comments on this paper? No, well, if not, I think thank, obviously, the work being done at the GM level, but particularly thank the work that's going on in our A&E departments up and down GM. We were doing that. There's obviously a huge effort going on. I think we should realise the amount of work that staff do in this period, so thank you for them. Okay, Berry Medicine Strategy, Kieran.
Thank you, Chair. I'm going to try and present to you today the work of our medicines optimization team over the last 10 years, and particularly draw on two areas where we've done some work which I think is worth sharing across GM, and that's in diabetes and implementing the national call for action on psychotropic drugs in our patients with learning difficulties. I'm going to take you through some of these slides. I'm going to whiz through some of them just to try and draw out the main learning points that we have. We started with this program in 2009. At that time, the graph on your left shows where we, as the CCGs in Greater Manchester, were in terms of our average spend per patient on prescribing costs. The bottom line is the England average. We obviously justified that on the basis that we had greater disease burden in the north of England, and that's absolutely reflected that differential. The graph on your right is where we are today. The red line at the bottom is the Berry average weighted spend on prescribing. We've achieved this cost reduction without compromising quality, and actually, I would argue we have improved quality and improved patient outcomes. And I'm hopefully going to try and reflect some of that in this short presentation. If we all got to the England average, there would be a £60 million saving annually on our prescribing budget. So just that's the context in which I want you to hear this presentation. In 2009, Berry were also in turnaround, which made it absolutely imperative that we did some different steps. And I think this was a forerunner to some of the work that we're going to now do in the transformation plan, because we used that kind of principle to make this program work. So how did we do it? We did incentivize. We did incentivize our practices to engage with this program. We built strong relationships between the CCG's medical optimization team and the practice. We embedded them in the GP practices. Again, lots of our plans that we're looking at now currently are planning to do this. We did this in 2009. They became integral members of the GP practice. We ensured that the cost efficiency work also incorporated some quality improvement markers as well. And we were absolutely honest with the patient. We told them that this was a cost-cutting exercise. There's a statement there that we use. If we treat an average 14 patients more if we used a cheaper drug. And that was a statement we put out to patients. And we used data to challenge well-held views. This is an example of the incentive scheme. The top line was to do with cost savings, but the remaining targets were all quality targets, some local and some national. So you will see that there was an incentivization around antibiotic prescribing and non-steroidals. These were national asks. This graph, the red line is the England average. The purple line is how this work over the last 10 years has shifted our position from being 21% above the national average to being below the national average. The blue line is the remaining GMCCG's average as it is now. The first program we did was to look at the group of drug statins which are used in lowering people's cholesterols. When we started this program, Berry was one of the highest spenders in GM. But we did not have the quality outcomes from that. So we were in the bottom 10% of outcomes from that level of prescribing. What we did, we took a brave step not just to ensure all new patients were prescribed the cheapest statins, but we actually said anybody who was previously prescribed a statin, we were going to switch them to the new lower priced statins. Clearly, there was some discomfort amongst the clinicians and in terms of the public as to this will lead to adverse outcomes. So we audited patients before the switch and throughout the switch program continued to audit them. I am happy to report that that switch demonstrated that there were more people on statins because of this program, because we improved compliance, because of that regular engagement with the patients, and we actually achieved better control in a greater number of people. So that active engagement produced better outcomes for patients. We did that same kind of program over a number of other areas. So you've got hypertensive drugs, you've got people who are on feeds. And so we did similar programs throughout the next few years. Then I'd like to draw your attention to the next, I think, really significant program. We changed emphasis again here. We looked at repeat prescribing systems within individual practices. We all run our own individual variation of the repeat prescribing system. We know there's a significant amount of drug wastage that happens, 10% by a kind of a conservative estimate. We worked with our local pharmacists, produced an ideal way of managing your repeat prescribing scheme, and we got practices to sign up to that. So there should be now a consistent way of handling repeat prescribing, which is known to practices, known to patients, and known to pharmacists. And what this graph demonstrates, the yellow line is the Berry line, is the growth in items per across the years. And the black line is the UK average, England average. So again, we're well below. We expect growth, but we're well below the England average in growth. So, diabetes. In 2011, when we were reviewing this, Berry had one of the highest spends in diabetic drugs across the north of England. But that wasn't coupled with improved outcomes. And there was huge inter-practice variation in the spend that we had. So we used the data, we identified practices' spends and what drugs they were spending it on. We put this in front of our clinical community, put some training and learning in place as well. So used the benchmarking data, got the medicines management optimization teams to work with the practices, identify patients, make sure the registers are accurate. Again, what this did was actually we put more people on the registers, which meant more people were getting the right care that they needed. We encouraged practices to follow NICE guidance, reviewed patients regularly in a structured way, and we looked at how practices were chasing QOF targets without necessarily achieving better outcomes. We wanted them instead to have a much more holistic patient-facing service and not just chase the targets. Just that program alone reduced our average spend, but we were challenged at that point by our clinicians saying that they could justify their spend because they had better outcomes. We analyzed that. What this graph shows that there was absolutely no correlation with spend with outcomes. So the outcome here, measurements here, are your attainment of QOF targets. So you can see there's no correlation. So again, using this data, we were able to re-engage with the practices. We then changed the emphasis of the program from cost saving to outcome measures and absolutely challenged practices to improve their outcome related to diabetes. So at this point, we started looking at admissions into hospital with diabetic-related issues. We got our community diabetes team and a consultant-led team in the community to work with our practices. We put targeted education programs in. So we identified those practices that were struggling, and we had a targeted education program around those with a diabetic team, community team. We ensured that we were using all the resources that were available to us through the NICE and GMMG, and sequentially we got costs and outcomes better controlled. Now we don't incentivize this program, we just use the GMMG guidance to make this program work. And what we have done is, in this graph, we showed hospital admissions related to diabetes versus spend, and we've moved towards the right part of the graph. Now, this is the bit I think my team are most proud of, the work that they have done around reducing antipsychotic drugs for people with learning difficulties. There was a national call. We know that antipsychotic drugs are harmful to people in the long run. They cause cardiovascular illnesses, they sedate and subdue patients. This was thought to be too difficult to do. These are a difficult cohort of patients, and to start changing the medication, people felt that this was going to be just too difficult to do. We had a very passionate leader, clinical lead in this program, who was not going to be deterred by those. She worked with our mental health provider, the consultant at the hospital, and the pharmacist there, and we put a program together. We reviewed every single patient who was on the learning disability register, who were on antipsychotic medication, and this chart you can read in your leisure, but shows the output of that. We had nearly 1,000 patients. 200 of those were on these drugs, and we went through a systematic process with our mental health leads, with our GP practices and the pharmacists, identifying patients who were on it appropriately, inappropriately. We looked at whether the dosages were right, the combination of treatments were right, and where possible we stopped them or we reduced the dosage. So you need a passionate leader for this program. You need collaborative working with specialists. The medicines optimizations team worked hand in hand with the GP practices, reassured them through the process because this was challenging work. And often there was backwards and forwards in terms of the dosage. You had to sometimes be flexible with the dosages. By that stage, we also had some primary care pharmacists in place, and we used their skills to help us guide the patients through it. And importantly, we connected with the carers groups, carers, care homes, and the community facilities where LD people worked. We had regular training events for GPs to make sure that there was reassurance that this was the right thing to do, and with support for them to handle that. And the output of this is some of the stories that I'm sure people may have heard in other fora around the care transform stories. So we captured these from the patients where we had reduced dosages, where their lives had been transformed. They were more alert, they were able to engage more in activities, and they just generally felt better. And also, we reduced their long-term harm from cardiovascular disease. So, the program that started with a money-saving exercise, with good, passionate clinical leadership, honest patient engagement, truly embedded medicines optimization team with the practice teams, support and training for the clinicians, which is targeted and not just blanket. Some peer challenge, that had to happen too, and a focus on quality. I think what you can do is have a medicines management program that moves from cost saving to improved quality of outcomes for patients and improve patient safety. Thank you.
Kieran, thank you very much for that presentation. Obviously, as you say, the 60 million savings is certainly headline grabbing for me, but I think your final point about quality is really important too, isn't it? It's not just about saving money, it's about improving. Adam?
Yep, so Adam Irvin from Pharmacy Advisory Group. I think it's absolutely crucial, as you say, Kieran, that all were involved from managing the angst that can cause and the switches, and it's really important some of the messages you brought about putting the perspective in place, and I think that's what we recognise. I think it's really crucial that here in GM, and I think we do generally see medicines as an investment rather than a cost. They are both, of course, but primarily getting the most out of the medicines is absolutely crucial, and I think that's certainly the work that we're doing as part of the Medicines Strategy Board and the other work streams we're doing in GM to make sure that's the case. I think there was quite a good balance in your presentation between outcomes and cost, and I think it's necessary that we do that, and we must make sure that patients are engaged in their treatment plans once they're initiated in treatment, and some of the work that we can do together that we have done already is very good there. You did mention that repeat dispensing, and I think it was back from 2013 from memory there, and I think we're probably at a stage where the repeat dispensing work's ready to move on. We've now got the electronic repeat prescription service where a GP describes the treatment interval, and that's the end of the involvement for the GP. It then is up to between the patient and the pharmacist to pull down the next medication. It also puts enhanced contractual obligations on the pharmacist to check that the patient's getting the most from the treatment, to check that a patient is still needing the treatment. So that's actually crucial in reducing the medicines waste that you mentioned. So I think that's something that we can work on, and there is work underway within GM to look at how we implement that more widely, because that's an area that GM's a laggard in. And I think crucial to that, it helps free up GP and practice time. It helps free up the pharmacist time because they're managing the workload. So enables delivering more person-facing agendas, whether that be to do with treatments already initiated, or whether that be towards a healthy living agenda, which we've heard various bits of there. So I think I really commend the presentation, but there's more work we can do and we are doing.
Sorry, Trish.
Just a quick mention to say, congratulations. That's a great demonstration of what working together and collaboration over a locality can do. There's just a few points I want to make. One is the expansion of the primary care or general practice workforce. It just relieves GPs from not having the time to do this piece of work, and look at the gains of bringing an additional workforce alongside them. We're often challenged to say that's taking GPs away from work, but this is just giving GPs time back to do what they're doing on frontline care and continuity with patients while somebody else looks at the medicines management. So it's really useful and great to say that we've rolled out this pharmacy work in terms of the workforce already prepared to take this on. So how do we do this from one locality to the next? You may remember that we had the GP Excellence Programme in collaboration with the Royal College of General Practice brought here as an MOU signing. This is a perfect piece of work to roll through that. So it's a collaborative work between GPs and commissioners with leadership and peer challenge and referencing that should get this rolled out quickly across our localities. But my third and last comment is just that this is a system approach. This is about patients understanding changes that are made. So that means we all share the narrative on this. We all share it in our communities of where the direction of travel is. And it isn't about cost reduction, it's about quality and maintaining that quality and ensuring that people only take medicines in the safest way that have the best response. So this is all of our work. Okay, general practice or secondary care clinicians may lead on it, but this is a collective piece of work for all of us.
Thanks, Tracy. Any further comments? Last word, Kieran, just a comment. Do you want to sum up? Okay, well, well done to you and your colleagues for what you've done in Barry, and we'd look to see it spread across the rest of GM. Wigan locality presentation, Will?
Thank you, Chair. Good morning, everybody. My name is Will Blandamer. I'm Assistant Director for Partnerships, Safeguarding and Reform at Wigan Council. I lead the Council's work with partners on wider public service reform and have been integral to the development and implementation of the locality plan on health and care reform. The purpose of this 5-minute, 6-slide presentation is to update the Partnership Board on our work in Wigan on integrated place-based working. Thank you for the opportunity, and I hope it picks up a couple of the themes that we've raised already in the meeting. Something weird's happening on the slides. I can't talk about drug. It's okay. Our objectives are pretty much the same as everyone else's: improving population health and well-being, managing demand differently, and reducing the cost base. In Wigan, we believe the large-scale application of asset-based working for individuals and communities is core to the achievement of these objectives, and you've previously had a presentation on that. We believe in creating opportunities from staff from different public services to work together in teams, understanding communities together and targeting proactive intervention as effectively as possible. We also believe in investing in communities, and as of next week, the Council will have invested £10 million over 3 years in the voluntary and community infrastructure in local places. The quote here shows the value of supporting residents to connect to their communities. The work on multi-agency teams in places, knowing communities, requires us to commit to a sense of place, where the focus of public services are on the people who receive them and the communities in which they live, and not on the organisations that provide them. The quote here shows how a multi-agency team supported some residents in a GP cluster. If there is a commitment to place-based working, then there needs to be a shared understanding or a currency for what constitutes place, at least for the purposes of integrating public services. So in line with the GM framework, there's been work in Wigan to reorientate primary care around populations of 30 to 50,000. This currency, in Wigan we call them service delivery footprints, and there's 7 of them, is the foundation stone of our integrated care organisation. We are building a more granular understanding of these places through profiles that not only focus on need and deficit, but also on the understanding of community assets in those places. The quote here on top in yellow shows that GPs are really beginning to value the wider public services wider public service connections being made in those service delivery footprints. So in common with others, our integrated care organisation, the Healthy Wigan Partnership, led by my colleague on my right, Rebecca Murphy, is building out of clustered primary care and providing the focal point for new delivery models. This includes integrated community services, a single management authority over community nursing, adult social care and community therapies predicated on 7 service delivery footprints. Our Start Well model, the alignment of public health interventions, so for example drug and alcohol services from April 18 are commissioned to deliver on a 7 service delivery footprint framework. And our colleagues in North West Boroughs who are currently consulting on a realignment of a substantial proportion of their community-based activity into the 7 service delivery footprints. The quote here, it shows the centrality of primary care to the place-based working. But we know that the determinants of health and care demand are to be found in wider civic society. So I'm just going to go back. Wider civic society. So in Wigan, over 40% of our high-risk cohort for non-elective admissions are adults of working age, characterised, a substantial proportion of which are characterised by complexity associated with homelessness or vulnerable housing, domestic abuse, debt, substance misuse and worklessness. And so the 7 service delivery footprints are also the foundation stone for our wider public service reform. A number of services are explicitly configured on this basis: Greater Manchester Police, Housing, the Troubled Families Programme, we call it Confident Families Programme, and the Complex Dependency Workers. We now have meetings of staff, we call them huddles, from different agencies meeting together in each service delivery footprint, coordinated by service delivery footprint managers or conveners. The service delivery footprint managers were funded through the Transformation Funding Phase 1 programme, so thank you for that, and recently the Council's confirmed that that capacity will be supported by mainstream funding in the future. Increasingly, staff aren't just turning up to service delivery footprint meetings or meetings in SDF areas and then going away again. They're staying there, they're doing their mainstream work and their regular work in those places, sharing the air and the milk, talking to each other, not referring to each other, but understanding the needs of those communities together. This is gaining significant momentum now, and some of the quotes on the slides indicate some real success. We are driving towards a single operating model for place-based working, regardless of a PSR perspective or a health and care perspective. And if I may, on behalf, referencing the words of the Mayor earlier on school readiness, the Joint Intelligence Unit and the Council are doing some work on risk stratification for school readiness to put in front of the partnerships in each SDF a preemptive identification of those children aged less than 2 who may be at risk of not being school ready, and working proactively with those, bringing the weight of civic society to support those children and families. So in Wigan, and increasingly, unless you can describe your service or proposition in a way that positively contributes to the integration of services around SDFs and in the spirit of asset-based working, you're doing the wrong thing and you're off the pace of reform. Place-based working in Wigan is supported by a number of other borough-wide functions. We have, for example, a multi-agency safeguarding hub based at Wigan Police Station, which currently has in it great GMP, obviously, but also housing leads, live well workers, mental health workers, action workers, domestic and sexual violence programme, victims of crime programme, and is also connected to our CSE and missing children's hub. The MASH is already working in a different way with residents in communities, achieving some remarkable results. For example, our repeat adult missing cases through GMP have reduced from 51% to 14% in 6 months. The connection between borough-wide working like the MASH and the working places is really, really crucial. Last year was spent creating confidence in this proposition. This slide demonstrates the enthusiasm of Jean, one of our community matrons, for the work that she'd been able to do with a family, drawing on the expertise and talents of a wider set of public services in addition to health and care services. This year, we hope to fully exploit the notion of place-based working through service delivery footprints in the spirit of an asset-based approach. And we anticipate arriving at a first single operating model for each SDF by Easter. We can see the benefit of this approach emerging through some key indicators around A&E attendances, formal packages of social care, demand reduction for GMP. We know there's more to do. We're working very hard to develop the proposition with schools because we believe that GPs and schools are foundation blocks of public services in places. And indeed, from April, North West Boroughs are rolling out a programme of work supported locally of school-based mental health link workers predicated on each SDF. So there's more to do, but our best advocates for this approach are the staff who are working in those arrangements. So I'll leave you with this from one of our Startwell workers, Helen, who'd be utterly mortified to know I've shown it in this forum. But I hope her enthusiasm for the new and liberated way of working, focusing on assets and with colleagues from other public services and places shines through. Thank you.
Okay, thanks, Will. Thanks for describing the working approach. Any further questions, comments? Warren?
Just to say and play back a comment I made before, really, this is, I think there's something kind of really special happening in neighbourhoods across Greater Manchester. This genuinely feels like where the magic happens, and I think there's definitely, it feels like it's the principal theme and the aspect of LCO development that's most energising people, and you know, Tracy and I and the work we're doing with the LCOs across the 10 are genuinely kind of picking that up, and it feels like the best time that you can spend is really understanding how it's starting to be coordinated and mobilised at the neighbourhood level. And what you find is that, firstly, it's the most significant disruption of the way that we've managed fragmented public services before. And starting to turn that head and start from where the residents are. Secondly, what you tap into, which is the most exciting bit, is you get a sense of a genuine love of the practitioners in the place, for the place they work in and the population they serve. And if I was being sentimental for a minute, it kind of reminds me of being an idealistic housing officer 25 years ago, and the way that we kind of used to work then. And I think we've all been complicit in pulling ourselves apart into professions and organisations over that period, and this feels like a genuine kind of a moral refitting of public service. And the more work we bring through on the LCOs, the more of this kind of excitement I think we can generate across Greater Manchester.
Thank Will for the presentation. I think what that presentation demonstrates to us all is that Wigan isn't waiting for the new legislation to arrive. Wigan, by its very nature, in doing this work, is actually upstream of the children's mental health advocate and the work that's going to happen in 2019. I think what's important is that we recognise that we might not succeed on this work straight away. We might try and fail, but at least we're trying to improve, and I think that's the point that comes through from Will. We might not get all of this right first time round, but we have the interest of local people at heart, and I think that that is the most important thing that we have to remember when we start to roll out the LCOs. Local people have to count and count strongly. So just thank you for that presentation.
Well, unlike Warren, I can't remember what it was like to work in public services 25 years ago, but I do remember sitting in many meetings in the Department of Health a decade ago, and I just wanted to say the two outstanding presentations that we've just heard, and they are truly outstanding, incredible examples of reform based around, I think as Bev Craig was saying before, around people and communities. They couldn't be further, you know, they are light years away from the kind of discussions that were happening a decade ago, and that kind of silo-based mentality that we were all stuck in. So I just didn't want to let the moment pass by echoing what I think Warren was saying. You know, we are always, aren't we, looking ahead to the challenges we've got, the problems that we're facing, but sometimes you do just need to stop and look back at how far we've already come in Greater Manchester, and the two presentations really do illustrate that. And if you carry on in this way, then really I think we can get back to a model of public service delivery that does have people at its heart and is truly groundbreaking in the support it provides. So I just think it's a tribute to everybody, and you know, as a Wigan Borough resident, I'm incredibly proud of the work that's being done here to support communities in a different way.
Thanks, Andy. I think this is really kind of, it pulls together things around place that we tend to divide things up inside organisations in a programme way, don't we? And across organisations. But the only thing for me that really connects things is the actual neighbourhood and the locality, and that's why we adopted this approach. That was the kind of philosophy and thinking behind it. And when we have a Start Well programme, a Live Well programme and an Age Well programme, quite often it's the same families and individuals who are involved in each of those programmes, and we're treating them separately for each of the, you know, the way that we carve ourselves up and our services. And it's been brilliant to see the way that GPs have responded to this agenda, really embracing it strongly. So in Lee, for example, where Andy lives, you know, Jem Wong's practice has been absolutely exemplary, really, in showing what can be done around this whole agenda. Can I just say something nice about Mr. Blandimer as well, please? Because we're having to, unfortunately, take him away from health and social care integration and move him on to this stuff on a more permanent footing. So we pinched him from Greater Manchester, but he's been absolutely pivotal in helping us drive this whole agenda forward. He wrote with Paul Lynch, who now John has pinched from our CCG. He wrote the locality plan, he wrote TF1, and he wrote TF2 as well, and he'll be greatly missed. I wonder if we could just give him a round of applause, please, for what he's done.
Okay, thanks for those comments. Thanks, Will. Move on then to the approach to carers, the Carers Charter. Warren again.
Yeah, sorry, me again. But I'm only going to do a few sort of introductory words, and then following a bit of a theme of the meeting, I'll take an opportunity to introduce a bit more authenticity with some colleagues who have supported and led this work over actually quite a while now, almost a couple of years since we started on this journey, I think. The paperwork for the item describes a proposal around a collective commitment that Greater Manchester is asked to make around supporting carers. It does really underline the importance of that as a step when we recognise that 1 in 10 Greater Manchester residents is a carer. Out of that 280,000, 70,000 of those carers deliver care for more than 50 hours of the week. And Greater Manchester is home to higher numbers of working age carers and young carers than is typical across England. So apart from, I guess the simple elements of committing to identify, understand the needs of carers and support them, there are some real prompts in here around recognising life beyond caring for individual carers. And the emphasis that we'll need to place through this set of commitments on supporting educational careers, on supporting working lives, and critically on supporting the health and well-being of the carers themselves, alongside the care that we support for their loved ones. So whilst we started a while ago on this journey, we were keen to, I guess, role model a different approach to how we put pen to paper, and particularly keen that the design of the commitment for carers, the Carers for Charter, and the information in the action plan that will help us deliver on those commitments was designed by carers organisations and carers themselves. So deliberately trying to make sure that this wasn't a kind of bureaucratic exercise. This was something that valued and drew out some genuine lived experience. And what the work points to are those key commitments around identifying carers as early as possible, around direct support for access to things like health checks that will support carers' own health and well-being, access to those kind of services and, well, communities, friendships, neighbourhoods, activities that would support their objectives to stay fit and healthy themselves. Some proactive steps in terms of supporting employment and supporting education and working with employers around being kind of carer aware and carer friendly, including all of the public service organisations, obviously, in Greater Manchester. And I think a specific recognition that you know, carers come in many shapes and sizes, and this is deliberately intended to reach all carers, whether they're young carers, older carers, parent carers, working carers. Or carers with looking after people with specific long-term conditions, whether it's dementia or HIV or whatever it might be. So we try to be kind of comprehensive in the approach, and the paperwork sets out the recommendations for the board. But I think before we consider that, it's worth just introducing a couple of colleagues who've led the work on our behalf. Lynn Stafford, who's the Chief Executive of the Gadam Centre in Manchester, and has been our lead through the VCSE reference group that you recall we supported the establishment of about a year ago. And Lynn's been a kind of constant presence and a constant supporter and facilitator actually of the work, and also David Williams, who apart from being a working carer himself is the chair of the Manchester Carers Forum. So if it's okay with the board, I'll just hand over to Lynn and David to offer a bit of a perspective, a bit of a direct carer's perspective.
Thank you, Warren. Warren's right, this work's been ongoing for nearly 2 years now, and I got involved from the beginning, and it's really fantastic from a voluntary sector point of view, representing carers, support organisations who obviously support on a daily basis unwaged carers, that we've been involved since the beginning. And this actually links into an earlier presentation. It feels like a much more bottom-up, community-led approach. One of the things that we did quite early on was consult with carers around designing the charter, which you will see before you in the paperwork. And we drew up a sort of a draft, and then we went out to various carers groups that we know around Greater Manchester, and we asked carers for their opinions. And the different carer support organisations and carers actually commented and made suggestions in various different formats. Some of the organisations hold regular coffee mornings or carers forums, so they took it along. Other carer support organisations organise like focus groups, if you will. That sounds a bit formal, but they organise groups of carers to comment. Others got really sort of well organised and had electronic surveys so that people could actually comment, because one of the things about carers is they don't have time. It's what we all forget, is carers don't have time. They're caring all the time. So actually to expect a carer to come somewhere to do engagement and consultation means that they have to find somebody to look after they're cared for, probably have to pay for that as well. So it's actually quite difficult to consult and engage with them. So we engaged with them through the forums where they're already being supported. And I have to say the response we got was great. The Carers Charter went through a number of iterations, Warren, and we got it in sort of carers' language as best we could. And there has been, since then, I'm pleased to say, there are now representatives from all the 10 Greater Manchester authorities, and we work as a group. David is a member, and we have representatives from the key carers support organisation within that local authority. So we now have a conduit by which we can actually link with and engage with carers, and we can take voluntary sector representation up to each of the different work streams that form part of the action plan which underpins this commitment to carers. So it feels like a lot of work over quite considerable time, but it does feel like we're starting to use that bottom-up community neighbourhood, actually communities of interest identity rather than geographical communities, and looking at how we can actually get people and carers, in this case, views on how we provide services and support to them. Thank you. So I'll now introduce David Williams, who's a colleague, both from Manchester Carers Forum, but he's actually, as Warren said, a working carer himself.
Good morning, everyone, and thank you for your welcome this morning. Just a point of correction, I'm not the chairman of Manchester Carers Forum, I'm the chief officer there. The chairman would probably kill me if I was to steal her thunder and take her title away from her. Because you see, Manchester Carers Forum was formed 25 years ago as a user-led organisation, a group of carers who came together to actually begin to pressure and to campaign for change. So I'm excited that 25 years down the line, here we are today, looking at adopting this Carers Charter, which is vital for the well-being of carers and for the maintenance of a really essential and important workforce upon whom we all rely. In 1995, it was necessary for me to take retirement from my role as a head teacher because of my caring responsibility for my partner then, who is now my husband. Whoever would have believed 35 years ago I'd be able to sit here saying that, yeah? He was at the later stages of his life at that time, and it was essential for me then to take time out from my career in order to provide what we believed at that time was end-of-life care for him, together with end-of-life care for close friends of ours who sadly ended their journey and died a few years later. And I was also providing care for my mother, as well as running a very large primary school. Bit stressful, really, bit heavy going, and something had to go. And rather than it being me, my job and my career had to take a back seat. I was sad about that. I was resentful of that. But the opportunity and the support I received through Manchester Health and Social Services enabled me to recover from my breakdown, enabled me to be empowered to study again, enabled me then to seek employment in a paid capacity again, and to begin to work in the way that I have been working since 2001 to bring about the changes that are necessary to ensure that carers are supported to carry on their caring role and to have a life of their own outside their caring responsibility. I say in an emotive but not unclear way that actually the support that we received enabled my husband and I to get our relationship back again, because I ceased to be just his carer and I became his husband who cared for him together with others. That's why I'm passionate about this charter. I'm passionate that the expectation that was there in the past that one person could do it all is now recognized as being an impossible task. But the recognition that carers are partners in the care that we deliver across Greater Manchester. I'm the beneficiary of successful professional work that supported me and aided me in my recovery, made life better for me and for my husband, and I want that for the rest of carers across Greater Manchester. It's with passion that I commend this charter to you and ask you to fully endorse it. Thank you very much.
Thank you, Dave. Very powerful words, Andy.
Yeah, follow that. I'm not sure I can actually, David. That was a wonderful speech and says it all really about the power of what this represents. I think it goes back to what Bev was saying again about seeing people, not patients, and not just the individual, but everybody around the family and everybody, partners, everybody around that person. I saw, I mean, it wasn't Tracy, but I saw somebody was at the event yesterday at Number 10 talking about man-marking people through the system. You know, that for me is the kind of language that gets it all wrong. You talked about language, Lynn. You know, it's the language of bed blockers, isn't it? You know, marking people who are a problem to the system. I mean, we've really got to totally get away from all of that. And that's why the Charter, talking about people fulfilling their employment, their educational potential, living their lives to the full, as David so eloquently just said, is where we should be. I think that the Charter speaks to that all the way through. Peter, just 2 points from me, if I may. I mean, I think it really reflects the way everything is being developed through the Greater Manchester Combined Authority, that we are writing our policies with people, not dumping them on people. And I'm so pleased that that carers organisations have been so involved in working with Warren and his team in the development of this charter. And I'm pleased to see that carers support organisations are referenced in the key principles. I would just like to see if we could go further in the spirit of the Concordat we've signed with the voluntary sector to say that carers support organisations should be not just shared with information, but financially supported too, because we know they can struggle. I'm pleased to see Pensioners Link from Lee here today celebrating their 30th anniversary this year, 5 years older than the Manchester Carers Forum. But I know it's a struggle for organisations that support carers day to day to get that support, and we've signed up to some fine words in the Concordat, and I think it is important to make those words real and support our carers organisations with ongoing core funding and not just bits and bobs of project funding here and there. The second thing I would just say is to see this as really a start of a journey, not an end in itself, and the charter ends here. If we're thinking about a new model of care, how do you give real meaning to that, to carers? And it is looking at whether or not, as we integrate our health and social care systems, that we may be able to give carers, young and old, one person to contact, one point of contact in the system, so they're not passed from pillar to post anymore. So Tracy talked about accountability, the accountable system. That would give accountability, I think, to carers if they could ring one person to ensure that the care plan is delivered in the right way. Obviously, these are developments that may come further down the line on this journey, but I think making this real and tangible for carers across Greater Manchester is where we should be going. But I just want to say my thanks to everybody who's been involved in the development of this charter. I think it is a watershed moment, David. I think this is groundbreaking in the significance potentially if we make these words real. And yeah, I'm very proud as Mayor of Greater Manchester to say once again we're leading the way in building a 21st century health and care system.
Thanks, Chair. Brenda Warrington from Tameside. I'm absolutely delighted with the work that's been done here, and have no problem in very much endorsing this charter. We all know that if we don't look after our carers, then the cost to the public purse would be absolutely phenomenal. And we have to look after our carers so that they can have a quality of life beyond just the caring role that they undertake. And I think, David, your experience, it's enlightening that, you're telling us what you've experienced, and I think it must be typical of many, many carers. And I do hope that through this charter, they can all understand that there is something beyond that caring role, that, whatever they want that to be. I simply have one question, if I might, Chair, and that is to ask the level of engagement in putting this together. I think it was mentioned that you managed to speak to all of the 10 Greater Manchester boroughs, the carers in the boroughs. I know that in Tameside we have a very active carers centre, and I wonder to what degree they have been able to help you shape, the final charter that we're being presented with today. Thank you.
Thank you for that. What we did, and when we did the charter, was we sent it out through carer support organisations that we were engaged with and asked them to engage with carers and comment back. So we took back, and as I said, different organisations did it in different ways, some of them. So we engaged with as many as we can, but it is quite difficult in terms of carers' time. I think originally when the Greater Manchester Health and Social Care Partnership was setting up, they had an online survey, and something like 100 carers from across Greater Manchester responded, because it's around that time commitment. So we tried to get it as far as wide. Now we've got the group set up, the Carers Partnership, and we meet every 6 weeks. We feel that we've got that interaction. And what we have got is representatives from our group on all the other work streams. So there's a work stream, say, about identifying carers or about carers' health and well-being. We've got 2 representatives on each of those groups, So what we're doing actually is for carers going and challenging in those work stream groups on behalf of carers. And what we're saying, a plea to other work stream leads is, if you want to test the models you're suggesting, let's ask carers. So that offer is open. So in fact, carers from across Greater Manchester should be able to input into what their care looks like in the future.
Chair, I think the reason that this charter is so important at this point in time in the Greater Manchester change agenda is that the new models of caring for very sick people now in the community as opposed to in hospital will put an enormous amount of pressure on families, neighbours to support health and social care workers to keep people out in communities. There's been carers charters around for the last 30 years probably, but this is important now because without this, the new models of care won't work properly. Carers need to be supported to help these new models of care work. There's an army of hidden carers in Greater Manchester, not just the ones who turn up in the centres. There's an army that are out there supporting. There's an army of parents who are caring and supporting children with mental health problems and SEND problems, actually, that we've heard about earlier today, often passed over. What I would like to see, Chair, is as the policies are developing and we start to monitor the effectiveness of the new policies that have been put forward today, we should be looking at the implications on carers in each policy. So the new mental health for children policy and the elderly and the frail and the new locality policies. We can't just part this charter. It's got to be an integral part of what we're doing now. Careful identification, careful support of carers. They're really important. Thank you.
So 2 points I want to make. The first is just to ensure that we recognise that the carers are not just an homogenous group, but actually we have different types of carers facing different sets of circumstances. And one of the things I want to make clear about this charter and the commitment is for all carers. And that includes parent carers, and it includes young carers, and it includes those who are caring for people with disabilities, and it includes those who are caring for older people, those who are caring for people with dementia. But all of those groups and others, like those caring for people with mental health conditions, need a differentiated approach. It is not a one-size-fits-all solution. One of the things I am proud that we've done in the last 6 months is actually helped the parent carers in Greater Manchester to convene for the very first time and supported them to do so. So I accept that challenge, Andy, around the funding of carers organisations. We've started that with the parent carers, but let's look at each of those cohorts and work with the GMCA to make sure that those groups are properly supported. The second point I want to make, which I suppose follows on in part, is that we will be holding localities to account for their delivery of the Charter and the commitment, and we'll do that through our assurance framework. So in future, in our quarterly assurance meetings, we will have a section around carers and around carer support. So for example, in the recent Q2 assurance meetings, I challenged Bolton because I had some feedback from young carers that the service in Bolton wasn't properly in place. Now, I got good assurance about that. That was being corrected, and the service was about to be rolled out. But we will use the assurance framework to ensure that this isn't just, something nice you stick on a wall, but it becomes a reality in terms of the lived experience within the individual districts.
Thanks for that. Just a kind of couple of quick points based on the comments that that colleagues have made. Because I remember, I think almost a year ago, when we were for this board in the same chamber, and we signalled the intention to bring through the charter and the commitment. And I think you offered quite a challenge then, saying a charter and a commitment won't be enough unless we're clear on how we translate it into action. And actually that really made us reflect, which is why I think we've placed so much emphasis on the action plan and the methods of engagement that we use, because I think you're absolutely right that the worst thing we could do is make a promise that we didn't follow up on. So we had to go back and do some detailed work on understanding the state of provision, support and receptiveness of the system in terms of identifying and supporting carers. So we've got an action plan that actually recognises where we're starting from, because this will be a bit of a journey that we go on together. I think it's important to recognise that an aspect of that journey will be because of the engagement that we've got with carers and carers organisations now. We've got the facility to help ourselves to hold each other to account against the progress on the action plan and the commitments that we've made. So just wanted to let you into a bit of a secret that the comment you made about 10 or 11 months ago had quite an impact in informing the way that we approach the work then on exactly that basis.
Okay, thank you, Warren. I'm sure we'd like to approve the commitment and charter. Thank you very much. Just to finish the agenda, date of our next meeting, 16th of March in Bury Town Hall. And finally, from me, I think today we lose the services of Anne Gibbs, who's been helping us on improvement. So thanks, Anne, for the work that she did. I'm sure we should note that down. And welcome Tony Marlowe, who's going to take over from our place. Thank you. Okay. Thank you very much. We went from P, but then we went that.